Hi, I'm Dr. Robert Watkins IV. I'm the Chief of Staff of our local hospital, and I'm the team spine surgeon for the LA Dodgers baseball team, the Rams football team, the Lakers and Clippers basketball, and the Kings hockey team. And my father and I, we treat just about most of the local colleges as well. Every sport, guys and girls, hockey, crew, rowing, everything. My disclosures for today's talk are not relevant. Your role as a spine surgeon, the key is to be the patient's objective advocate. You got to have their best interest at heart and help protect them, but also help get them back to the sport they love if they can do it safely. Determine the risks of playing with or without surgery. And if you decide to go without surgery, you need to have a plan for how to get them back to their sport. When can they shoot and throw and practice and lift weights? You can't just say don't have surgery. You have to guide them back to their sport. And having a structured rehab plan is the key to treat people non-operatively, as well as to treat them after the surgery to protect your surgery. The other key is to stick to the medical facts of the case. Do the history and physical and stick to the studies, and don't try and do anybody a favor, and don't worry about the press and the contracts and all this other type of stuff. Do your job as the doctor to the patient. Be their advocate, take care of them, and stick to the same message to everybody. Make sure everybody knows the plan. Sometimes we write out a calendar. This week we're going to do this, second week this. The goal will get to this point, and everybody's on the same page so they're less anxious. Here's an example of a college football player had a collision in practice, came off the field, had no pain, full range of motion, just a little discomfort when he put his helmet on. Well, he ended up having a lateral mass fracture. And the key to this is you got to be vigilant. You got to protect these people from themselves. They have a high pain tolerance, a lot of desire to play, a lot of adrenaline. You got to be very vigilant, make sure you're protecting them. Never forget, you're their doctor. Take care of them. The key to success depends on three main things. Make a proper diagnosis, do a proper history and physical, get all the studies you need. Don't be distracted. Don't be compromised in your care because you're trying to help people out by examining them in training rooms. Do what you need to do to make a proper diagnosis. If you do surgery, it's got to be minimally invasive and safe and focused in on what exactly is the pathology. And then you got to have a rehab program to try and avoid surgery and then also to protect your surgery afterwards. Cervical spine issues. They present with pain, neurologic deficits, burners, and then transient neuropraxic events. What's the difference between a burner stinger versus transient neuropraxia? The first one, burner stinger, well, that's usually a Sperling's maneuver, extension, rotation, compression of the dorsal root ganglion in the foramen on the ipsilateral side, down one arm. Usually it goes away spontaneously and the prognosis is good. Well, that's different than transient neuropraxia, which is a spinal cord injury, which can be burning and weakness into both arms or legs. If it's in both arms, then it's not a burner. It's going to be a spinal cord injury, a transient neuropraxic event, much more risky, more indicative of a spinal cord injury, and we need to proceed much more cautiously. The prognosis after a spinal cord injury, well, it depends on how severe was the episode. How long was the person weak or have the burning pain? Was it just a minute or did it last a whole day? And then what's the underlying pathology? How bad is the stenosis? Do they have disc herniations, kyphosis? What's the chance it'll happen again? What's the chance of a spinal cord injury? Depends on what's the underlying anatomy look like. When can they go back? Well, if they have full range of motion, no pain, non-tender, neurologically intact, completed all the rehab, that's a safe way to go back. Anything short of that involves a risk assessment. If they have a residual symptoms, you got to review the whole case. Cervical pathology we treat disc herniations, foraminal stenosis, spinal cord compression. Disc herniations. With a fresh disc herniation in an athlete, plan on 6 weeks out of their sport. Now, if they get back and they're totally normal after 3 to 5 days, they may be able to make it back in just a couple weeks. But sometimes disc herniations can take 3 months to make it back to their sport. So plan on 6 weeks. Worst prognosis is big herniations, neurologic deficits, severe pain, changes in the spinal cord on the MRI. Surgical indications are unresolving pain, functional neurologic deficit, and then it depends on where they are in their season and in their career, whether they should have surgery now or wait till the end of the season potentially. Surgeries involve fusions, artificial discs, and then the posterior foraminotomy. Fusion versus an artificial disc. Both surgeries decompress the nerves directly and distract the foramen. The fusion stops the motion, so it's most reliably going to treat a damaged nerve and protect it forever. An artificial disc replacement is a great surgery for an acute soft tissue disc herniation. The results are pretty similar overall. In our practice, in the general population, we treat 75% with disc herniations and only do 25% fusions. But in professional athletes, we're much more likely to do a fusion because it has the best chance of protecting a nerve, getting the nerve to recover, and treating it and protecting it for the next 3 to 5 years, which is how long most athletic careers last. The trade-offs are after a fusion, there's about a 25% incidence of adjacent level disease, as Joe Maroon showed. Our paper on athletes only showed about a 10% adjacent level problems. But then after artificial disc, the downside is you can get recurrent problems at the same level, kyphosis, facet joint pathology. And in head contact sports, damage and traumatic injuries after an artificial disc is an unknown risk. And there have been reports of traumatic injuries after artificial discs happening. Therefore, there's a risk in doing that in head contact sports. The third option is the cervical foraminotomy. And we have found that if somebody has posterior pathology especially, or if they have a shoulder abduction test that relieves their pain and a positive Sperling's, well then a foraminal decompression is a very good option. We use a microscope, we work from the opposite side of the table, we only remove about 30% of the facet joint. You really have to preserve the stability of the facet joint for this to be effective in a professional athlete, especially with any head contact. Cervical surgery summary, the fusion's the most reliable treatment. We reported 25 pro athletes, 80% returned to sport. The average was 9 months. We only showed about 8% adjacent level problems. The foraminotomy is a faster recovery, but people are more likely to have residual or recurrent symptoms. Wellington reported a reoperation rate of 46% in pro athletes, which is too high of a number. Artificial disc replacements is a great surgery for the general population, but it's risky in head contact sports. Postoperative recovery, foraminotomy, return to sport averages around 3 months. Artificial disc return averages around 4 to 5 months, and a fusion average return is around 9 months. Collision sports versus contact sports. Collision is more head contact, NFL, hockey, UFC, wrestling, and rugby. In ACDF 1 level, they probably can return. Foraminotomies can probably return. 2-level ACDF, we're not likely to let return unless it's under certain circumstances. 1-level artificial disc, it depends on the risk of potential injury to that level. Laminoplasty, probably not going to let them go back to a collision sport. Contact sports, more like basketball, baseball, soccer, these are unpredictable. Baseball collisions rarely happen, but then sometimes they happen and they're really severe and violent. So it's more unpredictable. Foraminotomy probably can go back. 1-level ACDF probably can. 2-level ACDF probably can go back, but we may not even recommend surgery. Laminoplasty may be able to go back. 1-level artificial disc probably can go back. 2-level artificial disc maybe can go back. Lumbar spine issues. Our recommendation is any athlete with 3-week history of back pain should get a bone scan with SPECT tomographic images to check for a stress fracture. If it's positive, get a CT scan to identify the pathology. If it's negative, then get the MRI. And here's an example of a CT SPECT merge where the red hot uptake shows the osteoblast metabolic activity. The athlete, the family, the trainer, the team, everybody can see what the problem is. They're more likely to be compliant with the treatment, which involves stopping the sport, which nobody wants to do. A lot of our patients come in with an MRI and not the bone scan because they come in from outside facilities. Well, if they've got edema on the MRI, you can treat it like it's a stress fracture. If there's no edema, it's probably an annular tear. But if somebody's not getting better after several weeks, get the CT SPECT scan to identify whether they have a stress fracture. Treatment for stress fractures, you have to stop the activity that's causing the pain. The treatment is trunk stabilization, back strengthening exercises. We don't brace or do any bone stimulators. You want to decrease inflammation, restore the strength, increase their flexibility of their hips and hamstrings, and then improve their cardiovascular capacity. Stress fractures, treatment, plan on them being out of sport for 3 to 6 months. We do trunk stabilization exercises right away. Do that for 6 weeks. If they're pain-free, then they can start doing more sport-specific exercises over the next 6 weeks. Any discomfort, stop the clock, go back to the activities you were doing that don't cause pain. Pain is the key. Any pain, stop doing the activity. Our trunk stabilization program starts in neutral, pain-free position. Learn how to lock the muscles in there. Then it works to more endurance and balance and coordination, keeping the spine locked in a pain-free position. 5 levels of back strengthening. Depending on how strong the muscles are, then people are allowed to do more aggressive activities. It's all in our app called The Back Doctor, which is free in the App Store and Google Play Store. Here's an example. 24-year-old pitcher. He had a stress fracture on the left, healed non-operatively. 95% of stress fractures we treat non-operatively. But then 2 years later, he had a flare-up of the opposite side. We treated it non-operatively for 8 months, was not getting better. Got a CT SPECT scan. His right pedicle pars lit up with osteoblast activity. The left side was cold. We did percutaneous, minimally invasive, computer-guided lag screws on both sides. The typically 3 stab incisions preserve all the muscle function. Return to sport is typically 5 to 6 months after that surgery. So the summary, direct pars repairs, we only do if somebody's not responded to conservative management after 6 to 12 months. We start physical therapy 6 weeks post-op. We get a CT scan between 3 to 6 months. Spondylolisthesis, most don't need surgery. But if somebody does need surgery, they're more and they need a fusion, they're much more likely to make it back to their sport if the fusion's done when they're a teenager rather than if they're in their mid-20s and midway through their career. It's much more challenging to return to sport after a fusion. Lumbar disc herniations. Treatment, anti-inflammatories, oral steroids. If they're not getting better, do an epidural. We only do epidurals for pain, not for weakness. Do the trunk stabilization program. Non-operative outcomes with disc herniations in the lumbar spine, 90-95% don't need surgery and make it back to sport. The average return is 3 to 4 months. It can still take a long time to get back to sport non-operatively. Surgery depends on the severity of the symptoms, the size of the fragment, the degree of underlying congenital stenosis, how they've responded to the non-operative program, and where they are in their season. After surgery, a microscopic discectomy, we start the rehab program 4 weeks after the surgery. Return to play is typically 3 to 6 months. They have to complete all the rehab, aerobic conditioning, get to the certain level of skill they need to do their sport, and continue the program once they've gone back to their sport. Our results, we reported on 85 professional athletes with a microscopic lumbar discectomy. The return to sport was 89%. The average return was 5 to 6 months. It depended on where they were in their season. Another way to phrase it is, if their season was playing 3 months after the surgery, 50% played in a game 3 months post-op. The average return was around 5 months. The keys to rehab. Our whole program is in our Back Doctor app. It's got the 5 levels of back strengthening. It also has the cervical program. So as their muscles get stronger, when they get to level 2 of the program, they can do non-impact cardio. Level 3, they can do their sport-specific exercises. It guides them back so that everybody can be on the same page and know exactly what they need to do to make it back to their sport in a safe manner. Thank you very much. Feel free to email me anytime at robertwatkinsmd@yahoo. If we can be of any help, please reach out. And like I said, our app is in the Google Play Store and in the App Store, and the whole program's in there. The key to treating athletes is you have to have a non-operative plan and a rehab plan after surgery so that everybody can be on the same page. Everybody knows exactly what needs to be accomplished in order to make it back to the sport safely. Thank you very much.